pleasure to invite you for this upcoming for this particular case series meeting, monthly meet. That is our 29th meet actually, and by God's grace is going uninterrupted. And this time, and we have a PDSA conference, so most people could not able to join that. But anyway, since we have to continue the program, we are continuing this program. And as usual, this program has two sessions of good case presentations with the discussions. And I would like to invite Mr. Swarnalatha ma'am and his team for first case presentation. As we all know, Dr. Swarnalatha needs no introduction because she's a well-renowned teacher, astute clinician, and she has been helping our program, that is Peculiar Case Series, a lot by having but even in our 11th hour, if you ask her for a presentation, she'll be ready with the presentations. And this is ma'am, her team has been doing this is the fourth presentation in our Peculiar Case Series. And ma'am has been a good guide, and she's mentor, is a mentor of many post-graduation, it must be around 80 postgraduate she would have mentored, and she has a lot of publications, 80 plus publications. And she is a reviewer of many international and national journals. And I remember from her postgraduate days of nephrology education emails. Every week or every second or third day, we used to get the articles through the emails when I did my residency. And she has a compassion towards the nephrology education, and it was the first platform we have ever thought at that time actually. So thank you, ma'am. Welcome you, ma'am, for this program. And joining her, and I'm going to present the second case, is Dr. Kunal Gandhi. She's an associate professor from...
Sir, you are not audible.
Hello, am I audible?
Yeah, you are audible. You are audible.
So Dr. Kunal Gandhi is an associate professor from Amrita Institute of Amrita Hospital of Faridabad. And going through his CV, I could see that he's a firebrand nephrologist. He's combining the cutting-edge medical technology with compassionate patients' care. And he's done a lot of work in ABO-incompatible transplant and highly complex transplant. He has invented his own protocols for transplant. And this case he's going to present will be a novice one, and many people would not have seen that actually, on infective complication post-transplant. And he has a DNB program, and he's been mentoring many of the students. And I hope that his presentation will bring up many of the things to open to the discussion. Welcome, Dr. Kunal Gandhi. And joining this program are the two eminent panelists, and I'm happy and to invite Dr. Vinant. And we all know that he's one of the important pillar of intervention nephrology and that INFORM group, and along with Jay Bala sir, he's been a right hand to Jay Bala sir in conducting and organizing that INFORM meet. And they have published on book like Essentials in Intervention Nephrology. And as for intervention nephrology, peritoneal dialysis, and also transplant, and whatever interventional procedures and the transplant, he'll be there ahead of everyone and sharing his views and all. And he's a good friend of us, and has consented to come here as a panelist. And I welcome you, Dr. Vinant. Your words and your inputs in these cases will value much. And Dr. Sachin Soni, he's heading the Department of Nephrology Medical Hospitals in Aurangabad, in Marathwada region. And he has over 800 transplants to his credit. And we had one of his presentations in our Peculiar Case Series group where he presented a novel case of hepatitis, either HIV donor to recipient, and both donor and recipient being HIV positive, that would to be a ABO-incompatible transplant. He has a credit of doing an ABO at the highest titer, that is more than 16,000 titers. And he could do that novel type of and complex renal transplants. And welcome Dr. Sachin to this program. And without wasting much of your time, and I invite postgraduate, Dr. Swarnalatha ma'am, a postgraduate going to present her case. Ma'am will be sharing her insights into the case. And Doctor, can you please start your presentation? And Dr. Shaitish Shankara, she's a senior resident, Department of Nephrology, Nizam's Institute. She's going to present the first case. ma'am will be.
Thank you, Rajan. I think we should all appreciate you for having such a program, continuing running for so many years. And we are always there to, share our experiences. And this platform, we are very fortunate. And this is a unique case because we rarely see such a vascular complication. And it is very catastrophic complication, ultimately lead to either the patient loss or the graft loss. But we could successfully, treat this patient. And further details, I request our resident, Dr. Sahith, to please present, and later on we can have a discussion. Sahiti, over to you, please.
Good evening, everyone. I'll be presenting a vascular challenge that we had encountered in a post-transplant patient that was a pseudoaneurysm. So our case was an 18-year-old female born of non-consanguineous marriage who was a known case of chronic kidney disease on hemodialysis for the past 4 years. And with no history of sensitization, she underwent a HBO-compatible renal transplantation on 15th March 2025 with a father as donor, and there's a haplo match, and there was no the cross match being negative. So left donor nephrectomy was done with single renal artery, single renal vein, and ureter. The renal artery was anastomosed to the right internal iliac artery and with end-to-end anastomosis, and the renal vein was anastomosed to right external iliac vein with end-to-side anastomosis with the cold ischemia time of about 30 minutes, and the induction being basiliximab. And patient had an immediate graft function on triple immunosuppression. So the immediate post-transplant Doppler was normal with normal peak systolic velocities. And the patient had reached the lowest creatinine of 0.46 by postoperative day 7, and the drain was removed, and the patient has urine output of more than 4,500 ml. And apparently the patient had a pretty much uneventful week. For the first week was pretty much uneventful, and she was planned for a discharge. But on postoperative day 11, patient had fever, dizziness, and vomiting with graft dysfunction, having a creatinine of 3.07 mg per dl, and there was a decrease in urine output of less than 1500 ml per day. So at this time, we evaluated and we saw there was some discharge coming from the suture side. So we evaluated, and then we got to know that it was Enterobacter cloacae, and she was given IV antibiotics according to the culture and sensitivity. So because there was a discharge, so we thought there might be some collection inside as well. So we did a non-contrast CT for it, and that did not show any collection. Subsequently, by postoperative day 15, patient was symptomatically better. The creatinine had been dropping. It was around 1.58. The urine output had improved to 3,800 ml, and there was no discharge from the suture side, and she was discharged. But on postoperative day 18, patient was readmitted with abdominal pain, sudden onset abdominal pain at the transplant site, and there was decrease in urine output, and the creatinine has rose to 2.01 mg per dl, and there was an HB drop to 6.4. She always had a lower HB because of secondary hyperparathyroidism, and there was a HB drop to 6.4 from 7.3. And on ultrasonography, we saw there was an 80 ml collection at the lower pole with communication with the kidney. At this time, so we again did a transplant Doppler, and that was supposedly normal with normal peak systolic velocities. With having an HB drop and a graft dysfunction and a collection, we went ahead with an invasive angiography from the contralateral transfemoral route, and that revealed that there was no active leak per se, but there was a focal stenosis here. Focal stenosis was there, and along with that was a very small aneurysm with it just adjacent to the stenosis. And there were a few ischemic areas that were seen. So having a thorough discussion with the urology and the vascular surgery team, and having outweighing the risks and benefits of the situation, that is long-term antiplatelets and stent thrombosis and stent infection, and being less than 2 centimeters of a pseudoaneurysm or an aneurysm, it usually resolves spontaneously. So we went ahead with a conservative management. By postoperative day 30, patient had improved. The creatinine had come down to 0.68, and the collection also had reduced to 50 cc, and she was discharged. Follow-up transplant Doppler was done on So this is in a nutshell the first 30 days post-transplant. So there was an HB drop at postoperative day 18, which was 6.4, and subsequently there was no drop. There was a graft. There was a graft dysfunction here at 2.01, but there was an improvement after that, and there was no further increase. Also, we had done many times blood cultures and urine cultures, which did not show any growth, so that we could find out the cause of aneurysm, but it was not there. And CMV PCR was also done, which was negative. There was an HB drop in postoperative day 18, but the DSA did not show any active leak. So coming to the follow-up, on postoperative day 40, we did a Doppler again. They did not show any elevated PSVs, and the collection was similar, 50 cc, and the creatinine was 0.72. But patient was readmitted in around day 70, and she had with UTI, and there was a graft dysfunction of 1.6, but she was discharged with 0.72 after IV hydration and antibiotics, with blood cultures and urine cultures being negative. A follow-up transplant Doppler was again done, and that showed a similar size collection, and the aneurysm was also of the similar size. So unfortunately, the patient presented to us on day 100 with sudden onset of decreased urine output with a blood pressure of 150 by 90. And there was a graft dysfunction showing 2.05 mg per dl of creatinine, and the HP drop was 6. The transplant Doppler was done, which showed there was very high peak systolic velocities at the anastomotic site, and also there were tardus parvus waveform in the hilum and the intrarenal segmental arteries. That is a slowly rising and a low peak curve was there with an increased acceleration time, showing that there was a significant stenosis at the anastomosis. Also, there was a very large narrow neck pseudoaneurysm at the anastomotic site, measuring 3.6 into 4.1 into 4.4 centimeters, having an eccentric thrombus with a yin-yang pattern, which is characteristic of a pseudoaneurysm. Also, there was a hypoechoic collection just medial to the transplant kidney, which is 4.4 into 3.7 into 5.2 centimeters, with no color uptake. So with this finding, we had went ahead with a contrast CT. So now the left side is a axial section showing there is a collection just adjacent to the kidney. It is as big as the kidney. It looks like it is coming from the kidney, but subsequently when we see that it is actually coming from the internal iliac artery. On the right side is a coronal section, which is showing the same image, same collection that is very big, as big as the kidney. It is compressing the urinary bladder medially, and it is compressing the transplant kidney laterally, and there is some hyperdensity inside as well. So for better demonstration, so we have this common iliac artery, which is represented by the orange color, which is dividing into an external iliac artery and an internal iliac artery. So the external iliac artery is quite round, and the internal iliac artery is slightly crescentic. And this crescentic shape tells us that this collection is arising from the internal iliac artery, and also the hyperdensity over here is as similar to the density in the artery. So it shows that is an arterial flow, and this is the eccentric thrombus that is there. So this is the pseudoaneurysm. So the CT showed that there was a 9.5 into 5.4 into 7.8 centimeters saccular outpouching from the anastomotic site, which was compressing the urinary bladder as well as the kidney. So after this, we had to do a therapeutic intervention. So we went ahead with a renal invasive angiography from the contralateral transfemoral arterial axis. And we could see here that there was an active leak that was going on. Along with that, there was also a stenotic part. So here is the common iliac artery, and there is internal iliac artery, external iliac artery, and there is a focal stenosis. And this stenosis, at this part, there is an active leak that is there. So this is the graft renal artery, and this is the internal iliac artery, and that the anastomosis is the stenosis. So DSA also revealed there was a 9.5 into 7.8 centimeters large pseudoaneurysm arising from the anastomosis, and there was a short segment stenosis, which is 6 mm at the neck of the pseudoaneurysm. So at this point, we had two options, that is doing a simple PTA, or we could do a PTA and stenting, or we could do a stenting and coiling. So as the patient had stenosis and we wanted to remove the stenosis, so for stenosis, we would definitely do a PTA, but we had to place the stent because we have to close the neck of the pseudoaneurysm. Right, so we went ahead with a covered stent. So we dilated and then we placed a covered stent over here. And after placing the covered stent, we could see that there was no active leak and the parenchymal enhancement had improved. So we placed a covered stent of 6 into 28 mm. Bentley stent was placed at the site, and there is a complete obliteration of the flow in the neck, and there was normal enhancement of the renal parenchyma. This is the covered stent which is placed with mesh-like structure, and this is the enhancement which being improved. So post-procedure, the creatinine had improved to 1.06, and the transplant Doppler showed that there was no residual stenosis. There was normal peak systolic velocities, and the thrombopseudoaneurysm has decreased in size from 9 to 6.2 centimeters, and there was no color flow. So just having a small brief review of literature. The vascular complications in the post-transplantation ranges from 6 to 30%, with maximum having renal artery stenosis, that is 75%. And the others are arterial and venous thrombosis, AV fistula formations, and our interest is renal artery pseudoaneurysms, which can be intrarenal as well as extrarenal. The intrarenal are around 5%, the extrarenal around 1%. The intrarenal are mostly because of an iatrogenic, because of allograft biopsies. It can be because of infections or because of atherosclerosis. The extrarenal part is most commonly because of infections, the infection being most common bacterial, that is Pseudomonas, and the second is fungal, that is Candida, followed by Aspergillus. Others can also cause like E. coli, Enterococcus, Enterobacter, Klebsiella, etc. And the other thing that can cause an external pseudoaneurysm is renal artery stenosis, which is around 0.5%. And the others is technical surgical errors because of a traction injury or a faulty suture can lead to a weakened wall and leading to formation of a pseudoaneurysm. So the incidence of this extrarenal pseudoaneurysm is 0.5 to 1%. The incidence of graft loss with this is around 56%, but it increases to 62% if it is because of an infection. And the overall mortality is 14%. The most common cause is infections, and this, depending on the site, if it is occurring at the anastomosis, it can be because of a vascular reconstruction issue, or it can be because of an infection. But if it is a distant site, it is most likely because of a mycotic pseudoaneurysm. So the clinical spectrum is quite broad. It can be a simple asymptomatic presentation, or it can be a life-threatening sepsis, septic shock, hemorrhage, and death. So the most common cause is bacterial. It is most commonly seen in cadaveric transplants than live transplants because of contamination of the cold chain, and this contamination can be as high as 40%. The most common bacterial organism we encountered is Pseudomonas, which is a rapidly growing, usually occurs in less than 3 weeks of transplantation. And second common is the Candida, which is the most common fungus found. It is usually seen after 3 months of transplantation. So lastly, coming to the transplant renal artery stenosis, this extrarenal pseudoaneurysm with a transplant renal artery stenosis is quite rare. It is less than 0.5%. Transplant renal artery stenosis accounts for 75% of the vascular complications post-renal transplant, with an incidence of 1 to 23%. It usually occurs from 3 months to 2 years, but most commonly it is seen in the first 6 months. So it can present with Bruy, refractory hypertension, renal dysfunction with a catastrophic pulmonary edema and a dramatic reversal after correction of stenosis. But it can also present as an incidental finding of 50% or greater stenosis with a normal BP and a normal graft as well. So the presentation, if it is less than 6 months, it is because of technical errors or it can be infections. But if it is more than 6 months, it is usually immunological, can be atherosclerosis, and can also be infections. It is also common that cadaveric transplants will have more chances of transplant renal artery stenosis because of increased cold ischemia time that is causing the endothelial damage, leading to fibrosis, intimal fibration, intimal proliferation, and leading to stenosis. So depending on the site of stenosis, we can see what are the causes. If it is a pre-anastomotic stenosis, it can be because of atherosclerosis or a clamp injury. If it is at anastomosis, which is most likely technical, and the technical part accounts for 40% of the transplant renal artery stenosis, and that can occur during organ retrieval, clamping, or faulty suturing technique. The post-anastomotic part is sometimes it can be diffuse, mostly it is diffuse, and can be because of an immune, that is a rejection, atherosclerosis, or a CMV infection. The CMV infection also causes the endothelial damage, which leads to vascular proliferation and stenosis. So the anastomotic error, that is during a suture, in end-to-end anastomosis with difference in texture and caliber between the donor and recipient vessels can lead to a transplant renal artery stenosis that will lead to a turbulent flow, high pressure, and weakening of the arterial wall, and that leads to a formation of extrarenal pseudoaneurysm. So the investigation of choice is color Doppler. The gold standard is obviously the invasive angiography. So lastly, the treatment. So more than 70% stenosis intervention is usually mandatory. When to go for a conservative management, if it is less than 60% and patient has a stable graft function with the Doppler parameters showing that the peak systolic velocity is less than 170 centimeter per second, and there is no hypertension or there's an easily treatable hypertension. Other thing we have is angioplasty plus or minus stenting. A simple isolated angioplasty has a technical success of 90%, a clinical success of ranging from 65 to 94%. That is reduction in the BP and improvement in the renal function, and patency improvement would be 42 to 100%, but there's a very high recurrence rate, that is 10 to 33%. But using a stent along with it would significantly reduce the recurrence rate to less than 10%. You usually use an ipsilateral approach from end to side anastomosis and contralateral approach for an end-to-end anastomosis. The complications are quite rare in the angioplasty plus stenting or angioplasty per se. It can be related to puncture site, arterial dissection, rupture, and thrombosis. So lastly, we have surgery, which is a rescue therapy. It is only done in case of an unsuccessful angioplasty if there's a very severe stenosis. The options we have are resection and revision of anastomosis, saphenous vein bypass graft, and localized endarterectomy. The success rate ranges from 63 to 92% with a recurrence of 10%. The complications are quite high. The graft loss is 20% and the mortality is 5%. So the management of extrarenal pseudoaneurysm, so the conservatively we can manage if it is less than 2 centimeters, and usually it resolves spontaneously. The repair indications per se are symptomatic pseudoaneurysm, or if there's a large pseudoaneurysm more than 2.5 centimeters and a larger neck of the pseudoaneurysm, and there's an increasing size or an eventual rupture. So the therapeutic options available are endovascular repair, that is stenting or coiling, and we have conventional open repair, or you can do a USG-guided percutaneous thrombin injection. So in our case, it was an extrarenal pseudoaneurysm secondary to a transplant renal artery stenosis. It was an early onset, that is less than 6 months. Patient was a young recipient and it was an older donor. So, and also the recipient was only 149 centimeters and the donor was around 180 centimeters. There was a size discrepancy, and we thought because of this there can be a difference in the texture and caliber of the vessels, and because of that there can be an anastomotic technical error leading to this complication. It was quite an unusual presentation because patient did not have any per se pulmonary edema or a fluid overload because of this stenosis. So there are a few case reports who had renal artery stenosis and presented with pseudoaneurysm, like a 64-year-old male who had underwent a cadaveric transplant with a delayed graft function, presented 2 months after post-transplant with fluid overload and refractory hypertension. And he had a peak systolic velocity of 310 with a pseudoaneurysm and treated with exploratory laparotomy with evacuation of collection and a bypass graft, and the graft function had improved. Similarly, a 51-year-old male who underwent a live transplant had immediate graft function, presented 18 months post-transplant with refractory hypertension and fluid overload with a peak systolic velocity of 405, and a pseudoaneurysm was there, and they did an endovascular repair and the graft function had improved in that well. So there are no particular studies per se, but there is a literature of 76 articles, 76 case reports, and that show the infectious and non-infectious causes of the pseudoaneurysm. So in this, the infectious causes were around 110, and the most common infection was Pseudomonas, and the non-infectious were around 40. And they had elaborated 3 cases. There is Pseudomonas, Enterococcus faecalis, and one was transplanted renal artery stenosis, and that also presented within 2 months post-renal transplantation and treated with endovascular, that is coiling, and stenting was done. Thank you. That's my case.
Thank you, Dr. Splita. Your presentation is fantastic, and the approach to the case and how you managed the patient is something to be rewarded. And Swarna ma'am, Please give your inputs, please.
Yeah, I think this we have thoroughly evaluated. The only positive, I mean, thing I could find is during the initial 1 month of post transplant, patient had a bleed, which has actually had alerted us, and we maybe went ahead with the angio. Like there was very small aneurysm of less than 0.5 centimeters. With lot of discussion, there was one school of thought was to go ahead with the stenting, but the other school of thought was like, wait, because it's very small and we could control the bleeding. So because that had happened and we were little vigilant and we were trying to follow this patient with the Doppler and other parameters. So that's the reason why probably we could detect early and then treat early. Otherwise, when we reviewed literature, they said that the outcomes are, little catastrophic because it may bleed, and then sometimes that we will end up in having a graft loss, or sometimes patient loss of because if it's bleed is significant. This patient also had a significant bleed. Hemoglobin was low, and we were little apprehensive by looking at the size, almost the size of the kidney. So that's then we have within few hours, I think we have arranged the procedure, endovascular procedure with stenting with covered stent. So I think that was a success story, I believe. And looking back, we have thoroughly evaluated the etiology as well, looking at the infection also. So we could not find any infection. The only reason we could, explain was the age. I mean, the recipient was a child and the father was the donor. So I think disparity in the vessels. And we cannot rule out the surgical technique because it is a very sensitive issue. So we can never say the technical technique. So ours being a high volume center, I presume that, the Cygnus technique would be, good. But however, it was actually a learning experience for all of us. And I would invite comments from the other chairperson, what their experience and their thought process in it. You're muted, you're muted.
Hello.
Yeah, you're audible now.
Hey, can I ask you a few questions, Dr. Swarnalatha madam?
Yes, please.
So the final pseudoaneurysm, how long was that? After 100th day, right?
Yeah, almost 3 months, yes.
So, and you did say that mycotic is ruled out, right?
Yes.
Because the appearances, the way it looks like normally a pseudoaneurysm of that size and that appearances is always a high chance of infected related. I mean, based the appearances I'm talking about. So if the function, I mean, whatever you did is great. I mean, the function is getting better and everything. So in these patients, keep a close eye.
Yeah.
Like repeated scanning something, because if it's mycotic, another aneurysm might come somewhere else in the body. So you should keep an eye.
Yeah, actually, we were also looking for
That's
the mycotic aneurysm only.
One part, I think whatever they have done is excellent job. Stent grafting is.
Yeah, our first suspicion was the mycotic aneurysm only. So that's why we have thoroughly evaluated. Now it's been 2 months, I think more than a month and nearing 2 months post procedure, and she's doing good. That itself rules out. Otherwise, it would have been like very fulminant course if it had been mycotic aneurysm. And I think stenosis one of the precipitating factor, because she had a renal artery stenosis at the anastomotic site. So that could be the reason of worsening.
Yeah. So the other technical aspects, you see, I before intervention radiology, I did 2 years of renal transplant surgical rotation in England. I've not seen a single anastomosis to internal iliac artery, unless the external iliac artery. Sorry.
It's echoing actually.
Oh, my voice is echoing, right?
Hello, Sachin, your voice is echoing. Okay. Go ahead, please.
Yeah. So no, I'm just throwing my experience of UK and US. Even in the US, I hardly seen an internal iliac artery anastomosis. It's always an external iliac artery. I'm just curious, Is it because of the easiness that they go for internal iliac artery? Because doing internal iliac artery interventions is easier, but because of the location, deeper location, the stenosis, I think I noticed more often than external iliac artery stenosis, like anastomosis. So this is my observation. So if there's anybody in the surgical field in the group, I think they should give some insight into this one.
So can I
Yeah.
speak once?
Yeah.
Yeah,
Go
so
ahead, Dr.
actually, I had spoken to all the surgery residents over here about this only. I was asking why why it is preferred to do an internal iliac. So their assumption is they say that if it is external iliac is they do and there's any block, there will be problem with the circulation. So that is the major reason that they prefer doing an internal iliac.
I think that's a wrong assumption, I would say. I would have done so many interventions. Hardly I've seen any blockage. Again, I can't talk for the surgeon. So intervention wise, external iliac is difficult because of the angulation and everything. But the blocking and everything, I'm not sure. The other thing is internal iliac, you are doing end to end. That means you are cutting the internal iliac artery. That means your other supply of the pelvic organs is a little compromised.
But the
So that's
contralateral is usually takes care of the entire circulation, sir, apparently. That is the reason they are doing for everyone, they are here doing internal iliac only.
The August protocol, surgeon's protocol is to go with the, internal iliac end to end, and then the vein is the end to site. So that is very been a routine protocol. And ours is a very high volume center. We do more than 100 transplants. I think this year we already crossed 125 transplants so far. And this stenosis and surgical complications are relatively less.
Okay.
And this, we thought could be a patient factor because the recipient was a child. She is actually a 15 years old child, and her growth is like, a stunted growth. And father, it's again a male to female. No? Father is a little hectic, hefty. So probably a male to female, and a child being the recipient. We thought these could be the risk factors.
Okay. Okay, good, man. One important or curious question, but how did you suspect that initially there was some collection? Actually, I wonder, why do you go for that angiogram? Actually, I didn't have done that at that.
Exactly, because there was a sudden drop in the hemoglobin, and then there was a collection in the the ultrasound and the Doppler. So it was hemoglobin, like as she has shown that in the chart, it was almost 5. 5 hemoglobin was 5. So we were little wondering whether there is a leak, and then which requires intervention. So we got the Doppler done. So Dopplers, they picked up little some stenosis. We wanted to confirm that, and then we did angio.
Fine, but the collection was not that much higher. It's around 80 ml initially. It was.
Yeah, initially 80, but hemoglobin drop was little. We were worried about the drop of the hemoglobin because sometimes you cannot pick up with a Doppler. So it will be something like hidden inside, or it may be something like around the kidney. So just confirm, and then we got it done. And that picked up a small aneurysm. It was very small, and we had a lot of discussion whether to go ahead and not to go ahead. In fact, radiology were little aggressive in putting stents in the same day, same procedure. So we have asked him to wait, and then we have contacted our vascular surgeon, neurologist. They said we will try to follow up, and then this being a child, we were a little worried. So that's the reason why we were actually following this patient.
Okay. Okay. I think so. That's no other chat questions and all. And thank you, madam. That case was wonderfully managed. And the thing you early intervened with the renal angiography, still I would not have done that actually. But that was a great insight from your side to do that angio and confirm that and follow up and everything. The procedure is one was great, and ultimately patient has improved. That is a good sign. And thank you. The presentation was nice. She has made a lucid presentation about the pseudoaneurysm and the transfer renal stenosis. So thank you once again, and we shall move to the next topic. Dr. Kunal, shall you?
Thank you. Thank you. Thank you for the opportunity, Rajan.
Thank you, ma'am. Please unshare your slide, Shukrit. Yeah, Dr. Kunal, can you please share your screen?
Yes, indeed. Mm-hmm. So I hope my screen is visible.
Yeah.
Okay. Okay, so good evening, everyone. So thank you for the invitation. I think it is great to discuss such very interesting cases, and I can see a lot of good friends around. So I think I'll do justice to this another case which I'll be presenting. So now I've written is at bone of contention. So there are a lot of unexpected things like we saw in the previous case, and there are a lot of unexpected things we can always expect after any renal transplant. Even a normal looking transplant can sometimes give us a lot of headaches. So I'll start my case. So Mr. A is a 59-year-old male, a long-standing diabetes, and he's our typical patient. So long-standing diabetes, hypertension, obese, BMI of 32. So the index presentation was in 2018 when he presented with a creatinine of 1.8. As with a lot of these patients, the early testing is not done. And when the testing is done, you find that the creatinine is already, it has gone beyond the stage of recovery. So he had a creatinine of 1.8, the proteinuria of around 1.3. We did a ultrasound which was showing a right side solitary kidney, smallish, around 9 to 9.5 centimeters. Probably by birth, there was no any history of any surgical intervention or any intervention previously. So there was no diabetic retinopathy at that time. So we did a further workup, and most of the workup was negative. So ANCA myeloma panel was negative. Apart from a significant past history of pulmonary tuberculosis 20 years back, there was no significant history. So the presumed diagnosis was diabetic nephropathy, and we started on all the supportive treatment at that time, what we could have done. So telmisartan 80 mg was on OHAs, insulin, supportive therapy, which is required as for any patients with CKD. Unfortunately, these patients tend to worsen and progress over the next few years. So he was gradually progressive. His creatinine was gradually progressive, and by early 2024, he reached a stage of stage 5. So GFR was somewhere around 13 to 14, and then that is when we started discussing about renal replacement therapy. So they were not very keen on dialysis, not very keen on initiating on dialysis. So the donor was the wife, and luckily she was a blood group compatible, so both were B positive, and we started working them up. So he was not on dialysis at that time. So workup was fairly okay, fairly standard, no cardiovascular comorbidities, and it was a fairly straightforward transplant. CDC and cross match were negative. There was no history of any blood transfusion. And so just before the dialysis, we put a temporary IJ catheter, gave him 3 sessions of dialysis, and he underwent the transplant in mid-June of last year. So our induction protocol, so as a protocol, as a unit protocol, so we give thymoglobulin to almost everybody. So generally the younger patients will receive around 3 milligrams per kg, and as you age, so we generally individualize and we give it around 2 to 2.5 milligrams per kg. So this patients, because long-standing diabetic and little obese also, so we try to give him thymo around 2 milligrams per kg, and his maintenance was pretty standard of tacrolimus, mycophenolate, and steroid. So surgery was uneventful. The post-surgical time and the post-operative period in the hospital was also pretty uneventful. So he had, he reached a nadir creatinine of around 0.9 milligrams, and he was discharged a week after the transplant in a stable condition. So his follow-up was also routine. So we keep tacrolimus around 7 to 10 for the first 3 months, reducing to 5 to 7 for the next subsequent 1 year, and around 5 to 6 for the lifelong. So mycophenolate, he received 3 tablets for the initial 3 months, reducing to 1 BD for the next 1 year. Steroids, we tapered to 5 milligrams for 3 months, gave him Valgan for 3 months, and generally we give Septran prophylaxis for 1 year. So he was doing pretty well. So he was a regular follow-up and pretty compliant patient, doing well. And his creatinine was always around 0.9 to 1, and sugars were luckily well controlled on a stable dose of insulin. Antihypertensive, luckily he was off on almost all his antihypertensive, and he was generally feeling that good health which you get with a successful transplant. was pretty much what we would have wanted in any of our patients. So that is what he achieved. So in March of this year, so he had a burning micturition and developed a high-grade fever with chills. So as we know, UTI is one of the most common infection in the first year post-transplantation. So his urine culture grew E. coli and it was pretty resistant. So it was only sensitive to meropenem. So he was admitted for 2 to 3 days in hospital, received meropenem thrice a day. Luckily, he became afebrile within a day of starting meropenem, and there was no graft dysfunction. He was maintaining his renal functions throughout. We continued, switched him to ertapenem, a total therapy around 14 to 15 days of IV antibiotics, which he continued to take at home. Urological evaluation was further done. His flow was not very great, so he was started on alpha blockers, and he pretty much responded to the treatment and routine. Again, he went on to his routine daily life, and he was doing pretty well again for the next 1 or 2 months. Now, the problem started in May of this year when he had persistent left hip joint pain, and it started to worsen. Initially, it was a mild pain. So, as with a lot of these patients, long-standing diabetes, so we always consider that maybe it is a neuropathic pain or his bones of, because so much of these patients have a lot of mineral bone disease. So possibly because of that, but somehow it started to progressively increase, and gradually it worsens that much that he was unable to walk without support. So he was not able to even walk towards the bathroom for his routine daily activities. An orthopedic consultation was done. Initially labeled it as just mild sprain, started on tramadol, paracetamol, gabapentin, as a lot of these patients will do eventually. Unfortunately, he just started to deteriorate with excruciating pain. Even in spite of 3 to 4 tablets of tramadol, Ultracet, his symptoms were not improving, and he developed a low-grade fever, was bedridden. And that is when we really thought that something is not right and we need to even review a little further. So an MRI of the hip was done, and it showed an osteolytic lesion around 2.5 to 3 centimeter, just anterior wall of acetabulum and associated with adjacent marrow edema. So this is the MRI. This is the MRI of the patient. This is the frontal view. So I hope you can appreciate this. So you can see this black is the marrow edema. And with reference, this is on the right side. So you can see this is the normal head of the femur, looks pretty white. And this is the acetabulum, and it looks quite clean. And if you compare this with this picture, this blackish spot is something is not right. So again, this is the cross-sectional picture. Here you can see this blackish edema. This is the edema around the acetabulum, and this is the normal bone in between. And if you compare it with on the right side, the whitish is the normal which you are supposed to see. And for the reference, this is the normal picture. So we are talking about this region. So this is where this particular lesion, and there was no other lesion. So this was just a solitary lesion somewhere here. So this is an osteolytic lesion of the left hip joint, specifically on the anterior border of the acetabulum. So considering his age, his immunocompromised status, we had a good discussion with our radiologist colleagues. And so the first, obviously when you see such patients, advanced age, immunocompromised, you have to consider a malignancy. So our first diagnosis, possible diagnosis, were an eosinophilic granuloma, plasmacytoma, possibly metastasis, and later on maybe some metastatic infection. Looking at, he had a UTI a couple of months back, so possibly could have been gone untreated, or maybe we could have possibly it has metastasized by the time we started treating it with meropenem. So that was some of the possibilities which we considered in this patient. So we did a myeloma workup, a retail myeloma workup, and everything was negative. We screened with a plain CT of the chest and abdomen, and there was no significant finding. So we did not do a PET CT, but this was a plain chest and abdomen CT. And there was no other lesion apart from he had a prior, as I said, a prior pulmonary tuberculosis 15-20 years back. So there was some fibrotic patches in the lung, and apart from that, there was no significant finding in any of these imaging studies. So this is the CT scan of the same lesion. I hope you can appreciate it. So this is on the right side. You can see this is the bone. So CT gives you a good idea of the bone. So this is the bone, and here you can see. So this is the lesion what we are talking about. The whole bone is being eroded. So this is the osteolytic lesion which we are talking about in this patient, and there was no other lesion. This was the single solitary lesion in this patient. So his high-grade fever from low grade became high grade. He was restarted on meropenem. As I said, we were considering that possibly that metastatic infection which could have spread to his bones also. And based on that, on the previous, though the culture, repeat cultures were negative, the blood culture, the urine culture of negative, but we started again him on a meropenem. Unfortunately, there was no significant improvement. He was admitted to the hospital. No, he was not eating. Although his creatinine was fairly okay at this time, but his general health was quite deteriorating. So ultimately, we decided that we have to do something about this, and a biopsy should be done. We did review the CT again because the place where this lesion was, it was difficult to do a biopsy. Putting a needle in that area, it was a pretty vascular area. The radiologists were not very comfortable. At the same time, the orthopedic surgeon was also not very comfortable looking at his so many comorbidities. Just that lesion and getting an open biopsy and with so many comorbidities. So we thought that maybe we should go and attempt a CT guided biopsy. So we were lucky to have very good intervention radiologists. So a CT guided biopsy was done. So here you can see this needle, and it was going straight into this lesion which we had discussed in our previous slide. So this is a needle guided, a CT guided needle biopsy for this patient, which was done, and luckily there was no complications and it was quite uneventful. So when we looked at the pathology slides, so we were really surprised, and you can see this. This is a yeast looking cell, and this is a capsule. So which goes unstained. This is an H&E yeast stain. So this is what a typical cryptococcal neoformans look like. So you can see, I hope you can appreciate multiple yeast cells scattered all around this biopsy. And this is the PAS stain again showing this, this encapsulated yeast cells, multiple yeast cells within the macrophages, as well as extra, in the tissues. So this was the final biopsy. This is the official biopsy report, suggestive of cellular and numerous variable sized yeast cell, narrow base budding with unstained capsule, and is typical of cryptococcosis. So we did a serum cryptococcal antigen by latex agglutination, which was positive. We did a fungal culture, and we got the report after 10 days confirming the initial diagnosis of cryptococcal neoformans. And luckily, it was amphotericin fluconazole sensitive, though it was resistant to flu cytosine. So our final diagnosis in this patient was a cryptococcal osteomyelitis. So this was just a solitary lesion. So we did not label it as disseminated because there was no other lesion suggestive of any dissemination of the cryptococcus in this patient. So on the initial pathology finding, we started him on liposomal amphotericin on 4 milligram per kg. We initiated on a flu cytosine 1500 twice a day. And generally, this is a very messy therapy and very difficult to give, especially in a post-kidney transplant patient with so many problems around renal dysfunction. His IV cannulas, there was not many good veins, so we were worried about the renal dysfunction. He was not eating well, so we were worried about the prerenal AKI. So anyways, we went ahead, started him on treatment. And because our culture, which was almost 7 to 10 days after the initial treatment, so because flu cytosine was resistant, we switched him on a high dose fluconazole. So we involved an infectious disease consult. Our consultant is there, a DM pass out from AIIMS, so who helped us in the management of this patient as well. As far as the immunosuppression were concerned, we stopped mycophenolate, reduced his tacrolimus by 50%, and continued on her 5 milligrams of steroid. So his further course, as expected in such patients, he developed AKI. He was not eating, his hydration status was not that great. amphotericin induced, his TAC levels went to increase to 12, and his creatinine jumped from 0.9 initially and increased to 2.3. So his TAC level were 12 even after reduction, and we had to reduce it further. So he was on 0.25 milligrams twice a day with 800 milligrams of fluconazole. So at this time, we stopped his amphotericin, just continue him on a high dose fluconazole of around 800 milligrams per day. Luckily for us and for the patient as well, his fever subsided, his pain got better, and after 1 week, gradually his creatinine reduced to 1.5. And we had a great deal of discussion whether to continue this patient just on fluconazole, as there have plenty of case reports that even if there is no systemic other features and the patient is not that sick, maybe you can continue on a fluconazole monotherapy. But no, we found that since any skeletal lesion is a sign of disseminated disease, so we restarted him on 3 milligram per kg of amphotericin, of liposomal amphotericin, and we gradually continued it for around 10 days. Luckily, he was able to maintain his renal function at this time. And I think I would like to point out that initially it was a generic version of amphotericin, liposomal amphotericin, and we switched him to Ambisome, which is actually the original liposomal amphotericin. And luckily, there was no worsening of his renal function. So current status, and this is almost around 2 to 3 months of therapy. So right now he's pain-free, he's afebrile, and he's able to walk without support, and he's back in spirits. His fluconazole we have reduced to 400 milligrams per day of fluconazole. Creatinine is, unfortunately, is still around 1.4 to 1.5. So we continued him on a tacrolimus, very low dose tacrolimus, around 4 to 5. We had gradually restarted his mycophenolate around 180 twice a day and continued him on a Visolon of 5 milligrams per day. So just a very brief review of literature. So if you see the historical background, so actually if you see the Cryptococcus neoformans was first described in an isolation from a tibial lesion. Most of us will remember Cryptococcus as a cryptococcal meningoencephalitis, and most of us will relate with meningitis, but it was actually found in a patient with a skeletal cryptococcosis, and it was not until we had this HIV and AIDS epidemic where it came into the limelight as an opportunistic fungal infection. So if you see the solid organ transplant, 8% are invasive fungal infection, and Cryptococcus is disseminated. If it is considered disseminated, there are more than at least two sites should be involved, or a primary site followed by a secondary site. So that is what we call as a disseminated cryptococcal infection. For our patient, although we have not done a PET CT, ideally we should have done, but we have not done a PET CT, but a CT scan was also not showing any feature suggestive of any other feature, any disseminated to any part of the body. And if we see the ratio of the organ involvement, most of them present with the CNS cryptococcosis, almost 60 to 70%. Then is the pulmonary, and then comes the skin. As far as bony involvement is considered, it is very rare, less than 5% in the literature. And isolated bony lesion, as far as our patient is concerned, is extremely uncommon. And as I said, skeletal cryptococcus is usually secondary to hematogenous spread from a primary pulmonary or a disseminated infection somewhere else in the body. So this is there is not much of data as far as the skeletal cryptococcosis is concerned, and this is one of the studies which I could find on the web. And this is they looked at all the case reports from the last 40 years. This was published in 2015. So 80 articles, 89 patients, just 89 patients. You can imagine how rare this is actually reported. The real incidence might be higher, but reported incidence is not that high. Most of the risk factors, steroid usage, diabetic, tuberculosis, connective tissue disorder, because a lot of these patients will receive some amount of immunosuppression. As far as the involvement is concerned, so most common is the upper part of the body. The vertebra is also quite commonly involved. If we see what our patient presented, it is very rare. Only 2 cases have been reported so far in this particular area. And most of these patients had some other lesion, most commonly the involvement of the meninges, skin, or the pulmonary lesions. And most often there is a delay in diagnosis because you don't suspect. No, if we also see, if we see at our patients, we almost, it was almost a month before we could actually diagnose this patient with what we finally had. So even in this series, there were 20 to 25% of the patients were delay in diagnosis was there, and it, almost a year up to initial presentation, the diagnosis was delayed. The treatment, most of this patient received some amount of medical treatment, and a few, almost 50%, received surgery in conjunction with medical treatment, and the response rate was good. While 12 patients died in this of the 80 in this case series. So, as I said, skeletal cryptococcosis can present with a single bony site or multiple lesion, and the systemic symptoms are often not present, hardly in 1/4 of the patient, and the most common is just non-specific weight loss, fever. And a lot of these patients will ultimately initially be diagnosed at tuberculosis, at times can even be not started on empirical ATT. So workup will should include a open biopsy. Ideally a biopsy should be done, and a histopathology and a culture are the gold standard of treatment, where you can identify and show the giant cells and the typical encapsulated budding yeast cells. As far as workup, any patient with lesion anywhere will have to be seen whether any dissemination is there. So a CSF with India-ing fungal culture, a cryptococcal antigen, a cutaneous lesion, a biopsy needs to be done. From the blood, a fungal culture antigen should be done. A lot of these patients will, especially in males, a prostate, they can the fungus can hide in the prostate. So fungal culture, a cryptococcal antigen should be done. And if there are your suspicion of a pulmonary lesion, fungal cultures, a BAL should be done from the pulmonary lesions. So unfortunately, a lot of the management is described predominantly in patients with underlying meningeal or a pulmonary cryptococcal, and there is no clear guideline as far as disseminated or skeletal cryptococcus is concerned. So most of our experience of the treatment is from the patients who have been treated for meningeal cryptococcosis. And it is generally felt, as I said, since skeletal is almost always because of some dissemination from other parts of the body. So the treatment is almost similar to what a CNS cryptococcus infection will be treated as. A role of surgery, not very sure. There is not much of data on it, but if there is a significant infectious burden, then yes, debridement and all should be done. And the goal is to prevent any meningeal involvement in the future. So these are the IDSA guidelines. This is for the CNS cryptococcal disease. The induction phase, amphotericin with flucytosine for 2 weeks, followed by a consolidation phase of 400 to 800 milligrams of fluconazole for 2 months, and then a maintenance for at least for an year. A very important thing about immunosuppression. Our first impression is that the patient is very sick and we should stop all immunosuppression or reduce it significantly. That actually causes harm because there is always a risk of immune reconstitution syndrome, the IRIS, which we know of, and that sometimes can present like a fulminant, a cytokine storms type of a picture. So the immunosuppression should be gradually slowed, and it should be not suddenly stopped. So first is always, if a high dose steroid is there, you decrease the dose of steroid, you eliminate mycophenolate for the time being, and the reduction of calcineurin inhibition should actually be last, because there is some data suggesting that calcineurin, especially tacrolimus, has some direct anti-cryptococcal activity, in vitro anti-cryptococcal activity. So you should maintain on a low dose of at least some immunosuppression. So the typical IRIS will present 4 to 6 weeks after you start on the treatment, antifungal treatment, as well as reduction of the immunosuppressants. A retransplant should not be done until and unless 1 year of anti-cryptococcal treatment is done, and ideally the CSF should be cleared from the cryptococcal antigen. So the recurrence rate as far as skeletal cryptococcus is concerned is low and difficult to prove. For a CNS patient, you do repeated lumbar puncture, you do repeated fungal cultures, so that can help. But for a skeletal, it is very difficult to do a biopsy. So there is no proven follow-up treatment. It is just, I think in our patient as well, So it is just a clinical symptoms and probably the imaging after some time, whether the initial lesion has gone. So symptoms, he's improved dramatically after the initiation of antifungal therapy. So I think that is success, what we would have considered in this patient, and we generally would like to follow up with repeat imaging in due course of time. So that is as far as our case is concerned. Thank you for your patient listening, and I think we'll be open to discussion.
Thank you, Dr. Kunal. Please unshare your screen, please. And it's well managed, and it's good that you could get the histopathology from the lesion from the acetabulum, and you suspected well, and you treated the patient well, and the patient was improving, and it's a good sign actually. So I too had a case of a discitis, multiple spondylodiscitis, and ultimately many times surgeons, neurosurgeons intervened and could not able to get the correct biopsy sample. Finally, with all risk, he underwent an open surgery, and we could able to pick up the aspergillus discitis, and the patient did well with this voriconazole. So once again, thanks and congratulations for managing the patient well. Dr. Sachin, your comments, please. I think
it's a well evaluated and well presented case also. It is the first time I have come across any discussion about skeletal cryptococcosis. So a learning experience for me. Just wanted to know from the doctor that he has already mentioned that he would offer one year prophylaxis, 1 year treatment with antifungal. But would he continue with the same dose of 800 mg, or is there any way he would titrate the dose looking at the tacrolimus levels, or what is his plan?
Yeah, so generally the recommendations are you reduce 200 milligrams of fluconazole is enough for 1 year, and obviously you'll have to look at the TAC dose quite frequently because we know it can interfere with the metabolism, and you can titrate regularly. I think you have to give. You cannot stop TAC because that is one of the most.
So he has completed 2 months of treatment, is it?
Yes, all more than 2 months now. So
and
it is
currently
now he's on 400 milligrams. So we plan it.
And you intend to drop it to 200 when you.
Yes.
And that would be your clinical judgment, isn't it?
So we plan to repeat imaging to see if it has gone completely, and if it is gone, though his clinical symptom, I think it is more than enough that his clinical symptoms have improved dramatically, and I think we can slowly start to taper his fluconazole as well. So we plan to do a imaging, and if that is completely negative as compared to his previous one, we will want to reduce his to 200.
Dr. Kunal, what is the cumulative dose you will target initial amphotericin B?
See the recommended dose is 4 milligrams, 3 to 4 milligrams for 2 weeks. That is the dose. So you can see the cumulative dose accordingly. So, but there are a lot of studies as well which have evaluated a single dose of 10 milligrams per kg of amphotericin, and along with flucytosine and fluconazole. So dose is variable. As I said, for skeletal there is no guidelines. These are the guidelines for how you manage a meningeal involvement. So the cumulative dose around will be that much for the patient. So 3 to 4 milligrams of liposomal amphotericin B for 2 weeks. That is the induction dose.
Did you add flucytosine?
Yeah, we initially started him on, but his cultures were negative. His cultures were showing resistant to flucytosine, so we changed over to fluconazole.
So induction of remission, that is clearance of infection, how do you assess actually? That is 2 weeks means it's not a magic number, no? So patient symptoms and signs and all. No repeat imaging needed, no, that time.
No, I think for that, as I said, for these guidelines are for meningeal involvement. So I'm sure you must have managed patients with cryptococcal meningitis, you do repeated CSF to bring down their the pressures. So you keep on checking. So the target is that the culture should be negative. So once the culture is negative, you can the antigen will remain positive for a long time. But if the cultures are negative, you feel that yes, there is some amount of clearance. So generally, it is seen that after 2 weeks, it is good enough. As I said, No, there are other studies evaluating a single high dose 10 milligram of amphotericin, and they have it is a non-inferior to the standard protocol. So I think
Okay.
it is more of a clinical judgment. For CNS, you do repeated
Yeah,
lumbar
fine.
puncture, CSF, and then see. For this patient, I think it was more of a clinical judgment.
Fine.
And because he was having AKIs and so many problems, I think we wanted, and is giving IV for a long time, I think did not make much sense.
Final question. Do you have any experience on using that amphotericin B lipid emulsion, that ABLC? Did you have any experience on using that for
No,
cost
yeah,
constraints, logistic issues?
yeah, I know. We have used that, and generally some amount of AKI is expected. So the dose is little higher. I mean, little lower than the liposomal. The liposomal 3 to 4, I think that is around 3. We have used that in not in cryptococcal but other fungal infections, and more or less, obviously, you cut down the cost, and the AKI risk is still there. Even with liposomal, some amount of AKI we have seen in this patient is still there, and in few other patients which we have treated with liposomal. The problem is that the original ambisome is, I think, and that is what our infectious disease colleagues feel, that it is different. Ambisome and the generic version of liposomals are different, so that definitely makes difference.
Right. I've used many ABLC, and the target that the daily dose can be as equal to that liposomal amphotericin B. We can reach the target much earlier. And I didn't see much of the more complications than that, actually. For economically constrained patients, we still use that ABLC.
Yes.
And the cryptococcal antigen, does it a marker? Is it a marker to see that disease activity has gone? Can we take it as?
No. It will remain positive for some time. Even in CSF, if it is positive, I think the gold standard is the culture. If the culture is negative, initial culture was positive, and you repeat the culture, if it is negative, that means clearance. The antigen can be positive for a long time. So the only help antigen will do is, suppose you do an antigen, it is positive, then it becomes negative. If you retest, it becomes negative. So that means you have cleared off the disease. And suppose after some time you find that the antigen is positive again. So that is suggestive of a recurrence, relapse.
Okay.
So, I mean, that prognostic marker, it can be.
So for monitoring, it's not useful, actually, from your saying.
No, it is not useful. It is not useful.
Based on the clinical improvement, and finally,
Yes.
the
histopathological, microbiological. So that is, for CSF it is, and for pulmonary maybe you can do pleural tapping if that is possible. That that is much more easier. But for other disseminated, it can be difficult to follow these patients.
So lastly, how do you going to actually monitor, and how do you close this patient actually?
So we monitor just as a normal patient. We plan to do an imaging, plan to do a MRI soon. And if there is complete cure, we plan to reduce the fluconazole, continue for 1 more year. So it's almost 3 months, or maybe 9 more months, and just monitor his clinical picture. And TAC level, obviously, it has been jumping all around. And unfortunately, his creatinine, which was 0.9 to 1, so it has settled around 1.4, 1.5. So I think we just continue to closely watch him, and we have reduced the immunosuppression as well. So he's on 180 milligrams. So he's around 60 years, received ATG. So I think he must be quite immunosuppressed. So I think we have reduced his all over the immunosuppression is in the lower end at present.
Thank you, Dr. Kunal. Well managed and well presented case. And thank you once again for the presentation. And with no other further questions, we'll come to the close of the program. And it was a wonderful, exciting session with 2 important topics being discussed. One is a rare pseudoaneurysm arising from the internal artery anastomosis. And we learned about how to manage such kind of vascular catastrophes and all. And second is being that cryptococcal osteomyelitis of the acetabulum, that is peculiar and a new one, and he has managed the case well. And we learn about that cryptococcus and how to monitor and all. We have a good discussion over that. And thank you, delegates. Thank you, speakers. You have taken a great job on explaining us your case and taking it forward. And I must thank the panelists. I could not. I'm a little bit. Vinay couldn't join because of he's being attending the peculiarity, that is PDSA con in Madurai. And thank you, Sachin, for taking part in this program and giving your valuable inputs. And we always welcome our delegates who have been the pillar of support for this program, and MQ team for giving us an AV support. And thank you once again for the wonderful meet, and we shall meet in the next month, first Saturday. Happy weekend to all. Good night.
Thank you.
Thank you. Thank you. Thank you.
Thank you. Thank you so
Thank you,
much.
sir. Thank you all.